Kia ora. I'd just like to acknowledge a colleague, David Wood, who helped me with this work at North Shore Hospital and who presented with me down in Dunedin. This is all we're talking about sort of technology really, and we've got this little test trial that we've been doing telehealth. But most importantly, I'd like to acknowledge you all. I think it's pretty impressive, a whole auditorium full of GPs on a Saturday. So without your permission, I've already put that out on Twitter and Instagram. But there you go. Okay. So, this is happening. I don't know if any of you, I don't even know if Samantha Bailey's in the room, but this is already happening in primary care here in New Zealand. And so I think it's useful for us to think about how we might use technologies to our advantage. We're both in the same situation. We've just got full-on demand. How can we use technology to help us deal with that demand in different ways? You may not know in the US, Kaiser Permanente, one of the big health plans there, their primary care, I think it's up to now 75% of their interactions with patients are done purely in a virtual sense, whether that's through texting, email, telehealth. It's a big change that's going on. And so from our perspective, we were interested to see how we might adapt so that we could help with the demand. So we ran across about 3 or 4 services, a little pilot study. So I'll just share the results for this. And then we've carried it on in our service and are tracking to see how it goes. So we just enlisted patients, and it was purely just at their choice. If we gave them the choice of having a telehealth appointment rather than a standard visit, and if they wanted to take it up, then we were very pleased. And we were interested, we tracked several measures. With each session afterwards, we would contact the patient for a survey, and the clinician doing the visit would do it. And so we were interested in all sort of issues, any problems with access or how the technology worked or didn't work, and what it was like for patients and or parents, because I was mostly talking to parents of children with glue or tonsillitis. And then, of course, we were interested in the staff experience. And then just as another sort of thing which is coming out about this is just how much sort of cost saving could occur with using this approach. And so in terms of how this came about, we got quite a lot of patients that didn't want to, and purely they just wanted to make sure they were seeing somebody face-to-face in a physical sense, which is fine. But we did have a large number who were primarily interested to try and save time. Because if you think about it, for patients coming to us in a clinic, they've got to drive across town, which is pretty a nightmare. They get to a car park, find a car park, pay for a car park. At North Shore, you've got to pay for your car park. And then you wait in a waiting room for half an hour, and you see an ENT surgeon for about 5 minutes, and you think, well, what the hell was all that about? So that's the sort of thing that we were interested in, really. And the other part we were also interested, we thought probably because most people were doing it from home, and so we thought they'd be just using a desktop or a laptop, but actually the majority were using a smartphone, which makes sense because that's the way that things are moving. Everybody's using their smartphones, and I think it's up to above 90% of all New Zealanders have a smartphone, so that was kind of interesting for us. One trouble we have, of course, in ENT is it's pretty difficult areas to examine, but as you'll know, there's all sorts of different technologies coming on board. And this is a kind of a cool little one called a throat scope, which was invented by a mum of kids in Australia who got so frustrated trying to use a wooden tongue depressor to look at her kid's throat that she developed this and went through that Shark Tank thing. And it's now been quite a successful device. And it's a clear plastic throwaway blade, which you snap onto a little plastic handle, which has got an LED light source. And so it's kind of a cool thing, but it helps us to at least get a better view. So this is just a snapshot of me up the top there doing an interview with a patient. And so we've been tracking with lucky, Waitemata is fairly progressive in its adaptation of IT, and we have a business intelligence tool that we use as our way of collecting all the data about patients and allowing us to slice and dice and look at all of these results that we got. So this was for the results that we've had from our ORL patients just over a period from October to July last year. And so you can see from this the range of patients is mostly kids, but it was kind of cool that we had a reasonable number of elderly patients as well, and that was David Wood was doing sessions for those patients, and some of the elderly patients are quite fine. They're used to using Facebook or Skype videos or whatever to talk with the grandchildren and things, and so it's certainly not necessarily a barrier. Did I have the and the other interesting thing too, ethnicity. Obviously, we've got to be a bit careful about some of this stuff. We could be potentially making things even more problematic for lesser advantaged groups. But we had about the right mix for our population at Waitemata DHB in terms of this study. And again, the most common thing we were looking at was for kids, for grommets or tonsils, but there was quite a good range. We were testing this out just to see. And obviously, if we came up against this issue about inadequate examination, then it might have converted to a patient being brought in to see. But we were mostly doing first specialist assessments, what they call FSAs. The reason this is pretty good for follow-up, and we can see patients. If having seen them once, then you've got that relationship and you can see them for a follow-up. And the outcomes are quite a bit of a mix. We were very keen to make sure that we didn't have to keep following up patients. We were trying to move them on into the next stage. And so the patients loved it, and it was very favourable. Most said that they're certainly happy to do it again. And we got lots of favourable comments, lots of free text comments came. But the best one I had was talking to a mum, and her child needed to have surgery and was quite sort of urgent. And I said, well, that's fine. We'll be able to fit you in the next couple of weeks. And she suddenly went quiet. She said, do you think we could just push that out a bit? We're actually in London and coming back from overseas. But she didn't want to miss the appointment. So that's why she had signed up for it. But that was the amazing thing. You can do it wherever, obviously. And our clinicians, basically a very biased sort of selection because we were giving it a go, were all quite favourable in terms of how it went. Quite a few little sort of technology hiccups, but overall we're certainly pretty happy. But this is a real interesting thing. Big cost savings from the patient's perspective. Not so much from our side, a wee bit of saving in terms of we didn't need to use nurses in a clinic room, so that freed up a clinic room. But a big saving for patients in terms of just the time, travel, and how that converted taking time off work. And then that also relates to the travel, but the carbon savings, which is why we're now patting ourselves on the back for making our contribution to global warming. So anyway, that was just a quick little one. Thank you very much, and very interesting to see.